Sajan VS. Since 8 years, I am working in Parliament as a nurse. Today, I would like to introduce not a new topic, but an important topic in palliative care, subcutaneous infusion. So, when I joined in Parliament in 2014, as like you are all, I am also very much confident and I was experienced by giving injection form of medicines through IM and IV like routes. But after coming in Parliament, I just experienced since 8 years. I am experiencing subcutaneous route of administration of medication is very much important in palliative care. So now we can move to about the subcutaneous infusion. So first of all, I just divided the layers of skin into just three forms: dermis layer, subcutaneous layer, and the muscle layer. So currently going to discuss about the second most layer, subcutaneous layer. So, and another name also there for the subcutaneous infusion. Anybody can answer? Another name or another term for the subcutaneous infusion. Can anybody?
Epidermis.
Any other?
Hypodermoclysis.
Yes, correct, ma'am. So now we can move to around the definition of the subcutaneous infusion or hypodermoclysis. If we seeing the term, only the term hypodermoclysis means we will get the meaning from the term itself. Just split the word hypodermoclysis into three. Hypo first part, dermo second part, and clysis third part. Hypo means below the level of dermis layer, subcutaneous layer only. Clysis means administration. So we can define the subcutaneous infusion or hypodermoclysis like the administration of small volume of medications like bolus type of medicines and large volume of medicines or infusions to the subcutaneous space is the subcutaneous infusion or hypodermoclysis. In small volume bolus type of injection means in any stat order or any frequency, the bolus type of medicines we injecting directly in a slowly manner to the subcutaneously. Large volume means for continuous infusion we planning, or for the hydration if any needed means also. If the mild dehydrated patient, we haven't planned to rehydrate means by subcutaneously we can rehydrate. That's like large volume of like infusion strip. So ideally the subcutaneous route we can use, already I told, mild to moderate dehydrated case means we can rehydrate by subcutaneously, but moderate to severe or severe type of dehydrated patient means we cannot give or we cannot rehydrate it by subcutaneously because the subcutaneous tissue absorption will be poor in moderate to severe and severe dehydrated cases. Then any patient is suffering with swallowing difficulty and severe dysphagia. So now the patient is unable to take oral form of medicines or food means we can give by subcutaneously. Then if we planning to give 3 liter or 6 pint of fluid we planning to give for a patient for a 1 day means we can choose the subcutaneous route for giving the fluid maximum 3 liter or 6 pint. About the explanation, while I am saying about this 3 liter means you will be confused how it possible. So we're going to explain about the in next slides. So I already told in palliative care, the subcutaneous route of administration is very much important. I already experienced, now also I am practicing. So in our case, palliative care, most of all patients I seen suffering with the nausea and vomiting, severe nausea and severe vomiting, uncontrollable vomiting cases. In some patients, they are vomiting, the vomitous content may will be the fecal matter also. That much severe vomiting and nausea cases means patient is unable to take anything by orally, food or medicines. Such condition for giving any for the symptom management, if any injection form of medicine we needed to give means also we can give by subcutaneously. And for maintaining the hydration level, so we can rehydrate it by subcutaneously. Then if one patient is suffering with the throat or esophageal lesion or any ulcer in mouth and the throat area means also they cannot swallow the food or medicines. So we can use the subcutaneous route. Then most of all the cancerous condition related with the gastrointestinal system due to the primary level or the prognosis level also at any time we can expect the intestinal obstruction, mainly in the GI cases cancer condition. In such condition, if the intestinal obstruction is occur means again orally taking medicines and food means it's inappropriate in such patients. It's not at all acceptable. So in this type of intestinal obstruction means also we can choose the subcutaneous route for the for giving injection or for the rehydration. Then unconscious patient, about the unconscious patient I am not telling about in the ICU setting. In palliative care setting the patient condition is deteriorating, patient is going to end of life stage, now patient is unconscious level, but now also we need to continue some medications for the symptom management or making the patient calm and comfort. For that, some medicines we need to continue as an injection form, or we need to maintain the hydration level of the patient for maintaining the quality of the patient. In such conditions also, for like that unconscious patient, we can give the injection and the infusion by the subcutaneously. Then, if one patient we seeing with the severe pain, example I am telling severe pain, now patient can score us like 9 by 10 or 10 by 10. That much severe pain patient is suffering and the patient is crying due to the pain. Such condition already, if maybe the patient is already in the tab form of morphine or otherwise any other tablet form or syrup form of medications. Now, is it a appropriate time for giving the oral medicines in this much painful situation? Not at all appropriate. So, in such conditions, we need to give some injection form of medication and control the pain or otherwise and any symptom. We need to control. Then only we can move to the again to the oral form of medication. So, in that such conditions, so we need to give some injection form of medication. We can choose the subcutaneous route for giving those injection form of medication. Then normally, not at all, if we needed for the patient, if it needed to give injection form of medicine only, we can give. Otherwise, if the patient is able to take by orally means, we will continue the oral medicine only. So along with the oral route, if we, if suppose suddenly the oral route of medication is inappropriate, becoming inappropriate for the patient, some conditions will occur if the patient is suddenly getting severe vomiting or patient is unable to swallow the medication due to the oral thrush. Such situation, patient is active only, but now patient can't able to take oral medication. Then we can give some medications, example tabumorphine, patient is taking how much dose means also. Fourthly, the patient is taking by orally, but now patient is unable to swallow. Then we can give same dose of morphine by rectally. We can give. We can make it as a space form and we can apply on the rectal region. So in some situation, the rectal route also becoming inappropriate. Example, if the patient is diagnosed with the C rectum, already maybe having any mass or any lesion or rectal bleeding or spurious diarrhea, these are all the some of the situation may will happen for making the rectal route is inappropriate for the patient. Then also we need to change the oral form of medication or tab or syrup form of medication to the injection form of medication. Such situation also we can use the injections and give by subcutaneously. Then we can move to the sites of injection. Which are all the sites we can give the subcutaneous injection? In which are all the sites we can give the subcutaneous injection?
Anterior abdominal wall.
Okay. Any other?
Deltoids.
Sorry, ma'am.
Upper arm.
Upper arm deltoids.
Okay.
In the abdomen.
Okay.
Thigh, sir. Thigh.
Okay. Thigh region. Okay. So these are all the some common sites we can give the subcutaneous injection. First one, upper chest.
Upper arm plus thigh.
Yeah, yes, ma'am. Okay, first one, upper chest region or intercostal plane. So this region we can give the subcutaneous injection. Suppose we choosing this area for the female patient means this upper chest region if we giving means be cautious about, don't involve in the breast tissues because it will damage the breast tissues. So while we choosing the upper chest region or intercostal plane, be very careful. Then already you told upper arm or outer aspect of the upper arm, both upper arm, lateral aspect or outer aspect of the upper arm, we can give the subcutaneous injection. So measurement we will say as like 7.5 centimeter from the level of the shoulder region, below the level of shoulder region, and 7.5 centimeter from above from the elbow region. That is the actual region. That's the outer aspect or the lateral aspect of the upper arm. We can give the subcutaneous injection. Then abdomen means around the umbilical region, means 2 inches away from the umbilical, that point around the umbilical region, we can give the subcutaneous injection. Then outer thigh or in thigh region, lateral aspect or lateral or outer aspect of the thigh region, we can give the subcutaneous injection. Then upper back. Back means in buttocks, outer quadrant or upper quadrant of the buttocks, just below the hip region. And both buttocks, we can give the subcutaneous injection. Then last one is the scapular region. Both backside, the scapular region, we can give the subcutaneous injection. These are all the common sites we can give the subcutaneous injection. But in our setting also, and for our patient also, we will educate the caregiver also for giving the injection in the upper arm and outer thigh, lateral aspect of thigh and upper arm. These are the common sites we making them to give the subcutaneous injection. Why? Because most of all the patient and the caregiver have no idea about the subcutaneous injection or subcutaneous infusion. This only is maybe the first experience for them. So in upper arm and lower arm means it's very much comfortable and they are very much confident to inject. Other parts are little bit complicated only for them. So as a part of the caregiver education, we and the caregiver also very much confident to continue the injection in their home setting also. We need to make them. So this region mainly we will select. If not at all possible for the upper arm and lower arm, then only we will move to the chest region, umbilical region, scapular and upper back. Other sides we will move. So these are all the sites we cannot give the subcutaneous injection. First one, lymphadematous area. Mainly if the patient is suffering with the CA breast means affected site limb already may will have the lymphedema. There is a fluid accumulation is there. If again we giving the injection in that limb means it not at all absorb. So we cannot give in the lymphadematous areas. Then already they are having any recently irradiated skin or scar mark. That type of skin sites already we see means also that area we cannot give. Then bony prominence and a near region to the joint. Then skin folds. Already the skin fold means obvious patient means the skin in between the skin foldings will be there. So in skin folds, we pricking means also we cannot ensure it's in the subcutaneous site. Maybe the superficial also will occur. So we need to avoid the skin folds. Then already any infection or inflammation sign is there means also we need to avoid. Then if we suppose choosing the umbilical region for giving the subcutaneous injection, already the patient is suffering with the ascites, means also we need to avoid. Otherwise, already their ascites is there. There is no absorption will occur. So we need to avoid. Then already the lower extremity having any pitting edema, not already I told about the lymphedema. Another case, already the pitting edema is there means also that lower extremity we cannot choose for giving injection because it will not absorb. Then any tumor site or any scar area, this means also we cannot give for subcutaneous injection because it will disturb the tumor and that cells. So, which are all the just I am asking, which are all the commonly you can give example for which are all the medications we can give by subcutaneously?
Insulin.
Insulin,
Insulin, sir. Insulin.
Okay.
Kinocards.
Vaccine.
vaccines. Okay.
Vaccine.
Inocarditis.
Measles.
Kinocards.
Okay.
Sir, measles. Vaccine.
Okay.
Low molecular weight.
Heparin, sir.
Okay. Okay, ma'am. Thank you for your response. So here I am listing about some of the examples of the medication. In our setting also commonly we using in as a palliative care angle only I am telling. In palliative care in our setting also commonly we give giving these are all the medications: injection morphine, haloperidol, injection midazolam, injection metoclopramide or Perino, injection hyoscine butyl bromide or Buscopan, injection fentanyl. These are all the common medications we giving subcutaneously. But studies are going on. Some more medications are proving us can give by subcutaneously. But in our setting, we commonly using these medications by subcutaneously. So these are all the some of the medications we cannot give by subcutaneously. These are also some examples only. Injection stemetil, diazepam, chlorpromazine, antibiotics. These are all the some of the medications we cannot give by subcutaneously because in while we giving, if any plan to give infusion means also normally for 0.45% to 0.9% normal saline only we can give by subcutaneously as like infusion. So no other things. In US, they are approving as DNS, dextrose normal saline also. They are giving by subcutaneously, but in our setting, we not at all practice like that. Only the normal saline we given by subcutaneously as infusion. In antibiotic, no antibiotics we practice by subcutaneously. So these are all the medicines can give and cannot give by subcutaneously. So for giving the subcutaneous infusion or if we giving a bolus type of injection means we can give by subcutaneously by using a single dose of medication by using syringe and the needle. Mainly we using 26.5 size of needle we using for pricking the subcutaneous area. But if we have one plan to continue the infusion or medicines, we need to continue for a time period. Means we need to keep one as like IV cannula, one thing we need to keep it there and we need to start the infusion on that selected subcutaneous area. So this is a procedure only. For this procedure, as like every procedure, we need to explain the procedure to the patient because already I told in palliative care setting, I also experienced like that. This subcutaneous route of administration is very, very new one and it is a new knowledge for them. So actually, while we giving the subcutaneous injection or infusion means that actual site, there is will be one mild edema will be there on that area. So we need to explain about that to the patient and the family, or otherwise they will misunderstand, like an IV cannulation area, this like edema is happening means it's not at all IV cannula, not at all pattern like that. They will feel as like that feeling they will feel in the subcutaneous area also. So we need to explain about the procedure to the patient. Then after explaining the procedure to the patient, we need to do the hand washing, we need to wear the gloves, then assemble every tubing and fluid items, what are all the materials we need to connect for the subcutaneous infusion. We need to select and assemble everything nearby side. Then after that, we need to select the site, which site. Suppose lateral aspect of left upper arm we need to choose, means after choosing the area, we need to clean the area. For cleaning, antiseptic solution soaked swab we can use. For cleaning, a circular motion from the center. Center means pricking part. That's from the center to outward. We need to clean by circular manner. And after cleaning, we need to leave for 2 to 5 seconds for drying. Then during the period of drying or after cleaning with by using the antiseptic solution soaked swab, don't again touch that area with our fingers, because there is that area we need to keep very clean. So after that, actually we using the needle mainly the SV set or scalp vein set or butterfly cannula we mainly using for as like inserting needle. So while inserting time, we need to maintain 30 to 45-degree angle. That angle we need to maintain while inserting the needle. For inserting time, we need to keep the bevel region up. Bevel region up means about these are all will show in the video also. A needle tip on cross section like on tip is there. That region is the bevel. That bevel region will be in upward only while inserting. After inserting and for fixing, we need to secure the SV set or butterfly cannula on that area by using on occlusive dressing. We can using and fix it on safely and securely. After that, we need to start by connecting the IV fluid or as like that infusion medication. So after starting, we need to adjust the rate. About the rate and volume, we will discuss in another slide. So as per the prescription from the doctors, we need to adjust the drip rate also after connecting to the subcutaneous that needle. So now we can see one video about the procedure. What are all the steps I already explained in the procedure? We can see it in the video. Then we can continue. So you're all already seen the video. In video, at last, it's shown us like we need to label the date and time. So with that, I am asking one question. How much days we can continue on subcutaneous site?
7 days.
Okay. Any other answers?
3 days, sir.
Okay, 3 days. Okay.
3 days, sir.
3 days. 3 days. Okay, thank you. So actually, theoretically, we saying us 5 to 7 days we can give, we can continue or we can keep one subcutaneous site. So we need to assess the site and some assessment we need to do. About that, we going to see in another slide. So theoretically, we can keep up to 7 days, but with before that, the patient is experiencing any pain or any other complication in our assessment also we see means also we need to change the site. So already I told, as per the prescription of the doctor, we need to set the volume and the rate of the medication. So here, volume and rate about that, 1 ml per minute. If we giving bolus type of medication by subcutaneously means, we need to give as a rate like 1 ml per minute. If suppose 2 ml or 3 or 5 ml of medicines, we need to give by subcutaneously as like bolus form means, we need to take that much time. 5 ml means 5 minutes. That much time in that much patients, we need to give the injection, or otherwise patient will feel the pain on the subcutaneous area. If suppose we giving us like infusion form means 20 drops per minute is the maximum volume. Then in first slides, I already told up to 3 liter or up to 6 pints of fluid we can give by subcutaneously as a part of the rehydration. That for that explanation here it is, in one site we can give 1.5 liter or 3 pint of fluid we can give maximum within 24 hours. In one more site we choosing means again 1.5. Like that, in 2 sites we can give maximum 3 liter or 6 pint of fluid we can give maximum within 24 hours or within 1 day. So it's another third sites, it's not at all possible. Only 2 sites only it possible for giving the subcutaneous infusion or injection. So here, theoretically again, I'm telling, theoretically we saying us 3 liter or 6 pint of fluid we can give by subcutaneously within 24 hours. But in palliative care, there is no need like that for giving 3 liter or 6 pint of fluid. For maintenance of the hydration level or for maintaining the quality of the patient only, if suppose we need to give on infusion means also, we can give by subcutaneously. So theoretically this value we can keep it in our mind. So in practically this much of fluid not at all is necessary for the palliative care patients. So as like every procedure, after the procedure also some things we need to keep it in our mind. So after starting the infusion or continuous infusion or as like drip infusion started by subcutaneously. So first of all, we need to ensure that within 2 hours don't cross 1 liter. Then after starting the infusion, we need to document about the infusion and about the medication in the chart. Then after the starting of the infusion, that infusion subcutaneous site we need to check after 1 hour. First assessment we need to, or first checking we need to do after 1 hour of starting the injection or infusion through the subcutaneous site. Then there is, what are all the things we need to check? It means there is any signs of edema or any leakage is there or not. We need to check. Mild edema is normal only. That edema not at all subsiding or edema is increasing means also it's a problem. So we need to check about the edema and if there any leakage is there or not. Leakage means also we can assume as like there is a poor fluid absorption in that area. So we cannot continue. So these are all the things we need to assess after the 1 hour, after starting the infusion. Then if already I told mild edema is normal only, the edema not at all subsiding means we can give a mild gentle massage. We can give on that area for subsiding. Again, it not at all subsiding and it's increasing means we need to change the site. So there is some advantages is there for the subcutaneous injection or subcutaneous infusion. First advantage is this is a very much low cost only, because I already told in IV route we giving any medication mean we will keep a IV cannula. You can just check the IV cannula rate. You're all very well known about the on IV cannula rate. From 75 or 125, 150 like that, some rates are there for the IV cannula. But here the SV set or butterfly cannula we using in the subcutaneous site means that SV set cost is only 18 rupees, 18 or within 25 rupees is there for the SV set or butterfly cannula. So comparatively, there is a very much cheaper than the IV cannula, this SV set. Then more comfortable than the IV administration. While administering the medication also, it's very easy, not only for the staff, for the patient also, it's very much comfortable while administering by subcutaneous is comparatively comfortable than the IV. Then in IV, we supposed to give it on injection or infusion, continuous infusion we giving means there is a chance for the pulmonary edema or fluid overload will happen. If suppose there is a poor fluid absorption by body means there is a fluid overload or pulmonary edema will happen on the IV route. Suppose it will happen in some times. So in subcutaneous route means there is a no involvement in the circulatory system. In subcutaneous side, we injecting anything means it will collect in the subcutaneous space and gradually it will release and absorb to the body spaces. So there is no involvement in the circulatory system. So in subcutaneous, there is no complication also will happen as like pulmonary edema or the fluid overload. Then insertion also very much comfortable for the patient and reinsertion also very easy for the staff and the patient also. So just imagine for the IV cannulation, what are all the painful procedures we just overall doing for succeeding on IV cannulation. So after selecting the site by using on tourniquet or otherwise the support of our co-worker, we need to tightly on tight on that area. We need to select the IV, then we will prick. If suppose it's not at all succeeding means again these painful process we will again repeat for succeeding for the IV cannulation. But there is this much painful procedure not at all needed for the sub-Q insertion because there is no IV route we needed for the insertion, only the sub-Q space. 30 to 45 degree angle only we need to maintain while pricking by using the needle. Then after pricking the subcutaneous space, we need to secure by using the tape. So this very simple insertion and less distressing for the patient and it is easy for the staff also. Comparatively, the sub-Q is more easier than the IV. Next. So if suppose already I told this subcutaneous injection or subcutaneous infusion, not only for the staff, after the patient discharging from the hospital in their home setting also, suppose on injection form of medication or infusion needed to continue in their home setting also, we can educate the caregiver also about the subcutaneous injection and the infusion. So, or otherwise, if on home care team, we need to visit the patient and the family. While visiting time, maybe the team will have only one nurse. There is nobody will accompany with them. So in that team, deciding for giving on sub-Q injection or subcutaneous infusion for the patient, they decided to start from now itself. So only one staff, they are not at all getting any support from the co-workers. So on IV cannulation is needed means there is a little bit tough for the staff. They are that much pattern, that much experienced staff also means they can do, or otherwise maybe one supervision is needed means they not at all will get for the staff in IV cases. But in subcutaneous means there is no supervision is needed for the sub-Q insertion. So already I told there is no involvement in the circulatory system. So there is no chance as like happening thrombophlebitis will happen in the IV. There is no chance here in the subcu. Then there is no systemic infection or septicemia will not happen in the subcutaneous route of administration, because I already told there is involvement in the only on the subcutaneous space. If any infection or any inflammation is happening means also it will occur on that localized area only, not at all involvement in the circulatory system. So there is no chance for becoming a systemic infection. So that's also one advantage is there. Then for IV cannula, just imagine today morning we put on IV cannula and we given one bolus type of injection through that cannula. There is no needed to continue any medication in daytime. Maybe another bolus of injection may we need to give it at the night time or next day morning. So this much time that cannula is closed only, maybe the blood clot formation will happen, and it will, due to that, the cannula may out. So we cannot continue in the same cannula. We need to choose another one. But here already I told there is no involvement in the circulatory system. There is no blood involvement with the subcutaneous space. So there is no clot formation. So at any time we can give and we can stop and again we can restart at any time. Today morning we giving one bolus injection means next day or maybe 2 days later also we can again restart, or we can give one bolus injection or infusion on same subcutaneous space. If there is no complication is happening means in the same site we can give. Next. So as like advantages, some disadvantages also is there. Already I told there is no inflammation and irritation chance is there. But if some cases the purely the steps during the procedure, we not at all maintaining the step, if there is a chance for the or possibility for the inflammation or the irritation on the infusion site. In some cases, it's happening. Then maybe some leakage will happen. Already I told we need to assess the area for the edema and there is any leakage or not. We need to assess. In some subcutaneous space, there will be a poor fluid absorption. Tissue will be in the poor fluid absorption. So not at all absorbing. So due to the fluid overload on that tissue, it will leak out. So there is a possibility is there. Then final one, some allergic reaction also we can expect. In some cases, the adhesive tape or that micropore or occlusive dressing, whatever may be we using for securing the set on the subcutaneous space, maybe that material is allergic to some patient means it will happen to the allergic reaction on that area. It's very, very rare only will happen. So these are all the some of the minor disadvantages may will happen while giving the subcutaneous injection. So these are all the some of the side effects or the complication may will happen in the subcutaneous injection or subcutaneous infusion. First one is the localized edema. Already I told mild edema is normal only. After some time, it automatically it will subside. Or if there is not at all subsiding or mild edema again be lasting there means we can give a gentle mild massage. By giving that massage spontaneously, we can solve the issue. If not at all solving, again the edema is increasing means we need to change the site. We can assume as it's a poor absorption area. Then second one, cellulitis or inflammation. Already I told the insertion technique in between the period. After purely aseptic technique, we need to continue. If suppose on poor aseptic technique, will they continue during the procedure means there is a chance for the inflammation or the cellulitis. So be very careful during the procedure. We need to continue the insertion technique in the aseptic technique only. Then pain or discomfort at the insertion site. Normally, there is no pain the patient will feel after starting the injection or infusion if we maintaining the rate and the volume. I already told bolus injection means 1 ml per minute, infusion means 20 drops per minute. That's the maximum value. So that rate and volume we need to maintain. If maybe the rate and volume is increasing means it will cause the pain or discomfort at the insertion site for the patient. So if the patient is reporting any pain means we need to check the rate and the volume and we need to readjust, and or otherwise we reduce the rate and the volume for solve the issue. If again it not at all resolving, again the patient is saying reporting pain means again we can assume as a poor absorption, fluid overload is happening on the subcutaneous space and it may will be the reason for the pain. So we need to change the site, we need to resite. Then suppose puncturing of blood vessel during the insertion. Not at all there is a chance while inserting the needle to the subcutaneous site, there is no chance for the puncturing of the blood vessel. So after keeping the SV set or subcutaneous needle on the subcutaneous space, we with the securing tap or occlusal dressing, we fixing the SV set or butterfly cannula on the subcutaneous site. The needle will be the inside only. So while keeping the needle, the patient can walk and can do their own activities and their daily living activities they can do along with the needle. So while they keeping the needle on the space, in between during the walking time or during their work, maybe any accidental hit they are getting on that space. During the accidental hit on the maybe in the door side or corner side of the wall, may that hit happening means the needle will accidentally will puncture any small capillary means there is a chance for seeing the blood or blood tinged fluid we can see inside the tubing along with the SV set. So if suppose any blood like that blood tinged fluid presence we seeing inside the tube means we cannot continue the medicines or infusion in that, we need to change the site. So at that time, whenever we seeing this issue, we need to stop the infusion or stop the injection and we need to change the site and select another site. Then hematoma around the insertion site. Normally it happening for the patient. If the patient is already receiving any anticoagulant medication or the patient is already having the issue like low platelet level. Such situation may be the hematoma formation will around the subcu space. So we need to check the history of their medication or the history of their illness. Then infusion device occlusion means in subcutaneous space also and IV route also for giving continuous infusion we can give by syringe pump or infusion pump. Here in our setting, we using syringe driver also. Syringe driver actually it is as like the infusion pump or as like the syringe pump. It is a mini apparatus only, mini on equipment. By using the battery only, this device is working. It's actually it is just a bigger size than the on mobile. So it's a small setting only. During their walking time, during the working time, the patient can carry the syringe driver with the medication. So it's very easy for transportation also. So these devices, whichever may be the device we using for giving infusion for the medication, in between any alarm or any sound is hearing means also we need to check the external tubing if there is any kingling is there or not. Anything means we need to check it and we need to correct it. Next. So as a nurse, what are all our responsibility? Already I told after starting the subcutaneous injection or subcutaneous infusion after starting. After 1 hour, we need to check. So next, what are all the things we need to do as a nurse? Every 4th hourly, we need to inspect the site. So after starting the infusion or injection, that subcutaneous space, we need to check every 4th hourly. What are all the things we need to check or we need to inspect? So there is any hardness or tenderness is there or not, we need to check. Then any hematoma formation is there or not around the subcutaneous site. Then already the inserted site, the infusion already is ongoing, but there is any leakage is there or not. Leakage is there means we can assume as it's a poor fluid absorption. So there is no use for continuing the medication in that same space. So if there is a leakage means we need to report and we need to change the site. Then any local tissue irritation is patient is complaining, any pain or any irritation patient is reporting means is there or not. Then any redness is there or not. Or then already I told any presence of blood or blood tinged fluid in the external tubing is there or not. Not at all will happen. If it may be happening means also we need to change the site. Then any displacement of the cannula. I already told adequate occlusive dressing or adequate tape is needed for fixing the SV set. While fixing time, not only fix the wings of the SV set, along with the tubing also we need to fix by using the adhesive tape. Otherwise, a accidental pulling feel is happening means also the needle will easily come out. So along with the external tubing we fixing means that much pulling effect will not happen for the inserted needle. So the displacement will not happen. Maybe during the work time or maybe the walking or their daily living activity they're doing time, maybe any accidental pull happen that displaced that SV set from the side means also we don't reinsert, we need to change and we need to put another SV set on the subcu space. So actually this one about that I already told, syringe driver. This one is the picture of the syringe driver. Syringe driver, already I told, it's a small portable battery driver only, as like infusion pump or syringe pump. Syringe pump, little big size only, and it need on stand also for fixing. But here this SV set, this syringe driver, while we using time, patient can carry this syringe driver it in a carry bag. So and they can continue every activity. So actually this syringe driver we can give around 24 hour or more than that also. Syringe driver actually 2 types are there. Per hour setting syringe driver and per 24-hour setting syringe driver is there. This syringe driver is a per hour setting syringe driver, means from 1 hour to maximum 24 hour. Up to 24 hour, this syringe driver we can use for giving medications as like continuous infusion. So and another one is 24-hour is there. 24-hour means minimum 24-hour. From that 24-hour, 48-hour, 72-hour, like that we can give. So this syringe driver, according to the doctor's prescription, how much time one medicine we need to give. According to the time period, we need to calculate and we need to set in the syringe driver. For just for an example only, I told and I just introduced about the syringe driver for you.
Thank you, Brother Sajan, for your wonderful study. It was very enlightening for everyone. So now the forum is open for questions. If anyone have any queries, any doubts, please feel free to unmute yourself and ask, or you can just type it out. Please, for those who are having enough mental strength, I can just see, ma'am, I'm sure about pronouncing her name right. Ingo. Zwangingo.
Swangingo.
I can see only her video on. Thank you so much for that. Thank you, Joshua and Surya, for switching on your videos. I believe everyone else will follow. So, any quick questions? Or we will assume that everyone has understood everything and we'll start practicing right away.
Thank you everyone for joining us. Thank you, Sajan. We'll see you in the next session. Bye.